Hi there, my name is Joan and I'm an instructor for the ACCN program. In this presentation, we will review the information from Module 3 on the use of neuromuscular blockade in the critically ill patient. I'll start by giving a brief review of the physiology of the neuromuscular junction, and then look at the medications we use to block these receptors. Then we will examine situations where we are most likely to use NMBAs, look at the adverse effects, nursing considerations, and finally monitoring. This diagram shows the neuromuscular junction physiology of when an action potential is carried from the axon of the motor neuron to the motor end plate. So starting with number 1, we see the action potential moving down into the axon by electrical conduction. Number 2, when the action potential reaches the nerve terminal, they activate calcium channels, which open up and facilitate the influx of calcium into the presynaptic terminal. Number 3, the increase in the intracellular calcium concentration triggers the fusion of the synaptic vesicles with the nerve terminal membrane. Number 4, once fused with the nerve terminal membrane, the vesicle releases its contents into the extracellular space, also known as the synaptic cleft. The chemical or neurotransmitters, in this case acetylcholine, are released and then bind to the corresponding receptors on the postsynaptic surface, which is the motor end plate. 5 and 6, acetylcholine binds to its receptors and opens ligand-gated sodium and potassium channels. These structures are designed to optimize cholinergic neurotransmission in order to produce an end plate potential, or EPP. The EPP is simply the net synaptic depolarization caused by the release of acetylcholine triggered by the nerve action potential. The EPP serves to open the voltage gate sodium channels in the postsynaptic region, which in turn results in an action potential that triggers muscle fiber contraction. Number 7, acetylcholine esterase degrades acetylcholine by cleaving it into acetyl and choline, and it allows for the reuptake and recycling of choline to produce more acetylcholine molecules. Its activity terminates the synaptic transmission. So now let's look at some of the neuromuscular blocking agents that we use clinically. We'll start with, there's 2 types, depolarizing and non-depolarizing, and we'll start with the depolarizing. Depolarizing blocking agents work by depolarizing the plasma membrane of the muscle fiber, similar to acetylcholine. However, these agents are more resistant to degradation by acetylcholine esterase, which is the enzyme responsible for degrading acetylcholine, and thus can more persistently depolarize the muscle fibers. This differs from acetylcholine, which is rapidly degraded and only transiently depolarizes the muscle. There are 2 phases to the block. The first is called the depolarizing phase. Depolarizing NMBAs cause muscular fasciculations or muscle twitches while they are depolarizing the muscle fibers. Eventually, after sufficient depolarization has occurred, it moves into the second phase, which is the desensitizing phase. And at this point, the muscle is no longer responsive to acetylcholine released by the motor neurons, and we get a full neuromuscular block. The prototypical depolarizing blocking drug is succinylcholine. It is the only drug we use clinically. It has a rapid onset of about 30 seconds, but very short duration of action, about 5 to 10 minutes, which makes it ideal for short-term procedures such as endotracheal intubation. So now let's look at non-depolarizing agents. Non-depolarizing neuromuscular blocking agents provide a wider selection with varying onset and duration of action, which we'll discuss a little bit later in the presentation. Unlike succinylcholine, non-depolarizing NMBAs compete with acetylcholine to occupy the receptor sites on the motor end plate, but an action potential is not generated. So once 70 to 80% of the receptor sites are blocked, full paralysis results. Keep in mind that both depolarizing and non-depolarizing NMBAs only affect skeletal muscle. so cardiac muscle or sensory nerves are not affected. There's also a specific and predictable order in which which the muscles are affected, and we'll be discussing that a little later on in the presentation. This diagram looks at what is happening at the receptor on the end motor plate. When we administer a depolarizing medication such as succinylcholine, the receptor will be stimulated, but instead of then being quickly degraded by acetylcholine esterase, the drug will stay attached to the receptor, preventing further stimulation and causing paralysis. In contrast, when a non-depolarizing medication such as cisatracurium is given, it competes with acetylcholine for access to the receptor. But when it attaches to the receptor, there is no stimulation. In order to cause paralysis, it must block acetylcholine for more than 70% of the receptors. Here are the common neuromuscular blocking agents we see in critical care. I already mentioned succinylcholine, which is the only clinically relevant depolarizing agent that we use. On the non-depolarizing agent side, there is pancuronium, which was very commonly used previously, but we no longer can get it in Canada. Vecuronium, atracurium, cisatracurium, and rocuronium are the other sort of standard paralytics we would use in the critical care setting. Adverse effects of succinylcholine include hyperkalemia, dysrhythmias, hypersensitivity reactions, muscle pains, rhabdomyolysis, and it can trigger malignant hyperthermia. Succinylcholine is also contraindicated in patients with increased numbers of acetylcholine receptors, so patients with spinal cord injuries, neuromuscular disease such as Duchenne's muscular dystrophy, trauma patients, and burn patients. Here's a table of the more common non-depolarizing NMBAs with varying pharmacokinetics and adverse effects. The choice of which medication to use is often based on this information. Pancuronium is no longer available in Canada, but it was a common choice in the past. Its cardiovascular adverse effects, however, make it less desirable now that newer formulations such as vecuronium and rocuronium have come along. These new medications do not cause tachycardia, but do have the potential to elicit a histamine response. Cisatracurium has the added advantage of being metabolized by spontaneous chemical degradation, or the Hoffman degradation, which makes it a better choice for patients with hepatic or renal failure. Some common adverse effects seen in non-depolarizing NMBAs are rashes, pain at site of injection, tachycardia, and hypotension. As mentioned in the previous slide, there's some slight variation depending on the medication. NMBAs have both short-term and long-term indications in the critical care setting. Some examples of short-term use, generally considered paralysis for less than 2 hours, are facilitation of intubation, diagnostic tests, and operative use. NMBAs are also used for longer periods of time to facilitate oxygenation and ventilation, to reduce metabolic demands, and to control status epilepticus. For example, a patient with an ARDS situation may require an advanced form of ventilation, such as an inverse ratio ventilation, which is typically uncomfortable for the patient and difficult to manage without paralysis and sedation and analgesic. It is important to consider the immediate consequences of chemical paralysis. The patients have no ability to move or respond. They have no cough, gag, or corneal reflexes. It does not suppress gastric motility, but immobility does, so this is one of the consequences you can see with constipation in these patients. It is therefore necessary to assess the patient for the depth of the blockade using peripheral nerve stimulator and clinical indicators, and assess for factors that can potentiate or antagonize the NMBAs, which may change the dosing requirements for that patient. More intermediate and long-term effects that can be seen with paralysis, chemically induced paralysis, is the patient is at risk for all the deleterious effects of immobility. So they're going to be increased risk for pneumonia, skin breakdown, corneal abrasions. Prolonged muscle weakness can also occur, but recent literature indicates that this is less common if appropriate dosing is given and may reflect the underlying disease more than the actual medication. It is also vital to remember that NMBAs do not provide analgesia or sedation. If you induce paralysis, your patient is at risk for locked-in syndrome, as they still maintain sensory perception, so they can hear, they can feel, and they can process information, but they cannot respond, not even blink their eyes. For this reason, we always give sedation and analgesic to patients who are chemically paralyzed. When caring for the chemically paralyzed patient, there are some important points to remember. Because the patient is unable to breathe on their own and has no way to indicate distress, it is paramount that all relevant alarms be appropriately set, and mechanical ventilation must be in a controlled mode, such as assist control. Emergency equipment should be available prior to inducing paralysis. As previously discussed, adequate analgesic and sedation must be in place. It is important to carefully monitor the patient's response to the NMBA and titrate based on that assessment. We will be discussing this later in the presentation. Finally, your family needs to be aware that this is a temporary measure used to facilitate treatment of the patient's disease pathology and therefore is not permanent. Also advise them that they can talk to and touch their loved one, but he or she will not be able to respond while paralyzed. When patients are receiving neuromuscular blocking agents, they need to be monitored very closely. In addition to monitoring the patient for safety reasons, care must be taken to provide the only amount of drug necessary to achieve the desired effect, typically defined as about 75 to 90% neuromuscular blockade. Prolonged use and complete blockade with these agents may cause residual weakness after discontinuation of persistent pharmacological-induced paralysis. Use of a transcutaneous peripheral nerve stimulator in the ICU assists us in optimizing neuromuscular blockade therapy by reducing the risk of NMBA overdose and allowing an assessment of the blockade that is independent of confounding variables such as sedation. The peripheral nerve stimulator should be used in conjunction with clinical monitoring. Some of the clinical indicators that there is insufficient neuromuscular blockade are desaturation, coughing, initiating of respirations, asynchronous with the ventilator, triggering the ventilator, increased ICP, shivering, and movement. As mentioned previously, when we administer a neuromuscular blocking medication, there is a predictable sequence to paralysis of the muscles. We begin with the muscles of the eyelid, followed by the muscles of the arms and legs, then the jaw, intercostal muscles, abdominal muscles, and finally the diaphragm. The process of recovery is the same in the reverse order, so depending on the clinical signs you are seeing, you can extrapolate the depth of paralysis. In conclusion, I would like to highlight a few important nursing considerations. First, the use of sedation and analgesic is an important consideration for a paralyzed patient. Once a patient is paralyzed, they have no way of communicating discomfort and anxiety. So as a rule, we ensure that the patient has adequate sedation, such as midazolam or propofol, and analgesic, such as fentanyl or morphine. We need also to ensure that we are giving the least possible amount of paralytic necessary to meet the objective, and will generally use a combination of both clinical signs and response to peripheral nerve stimulation to determine the best dose. Make sure you are clear on the goals of therapy so that you are appropriately medicating and monitoring your patient. And finally, make sure you are clear on the policies and procedures associated with the administration of NMBAs and peripheral nerve stimulation monitoring. In many areas, administration and monitoring of NMBAs is considered an advanced competency. If you have any questions regarding this presentation or the related course materials, please contact your instructor.